Good morning, everybody. This is Dr. Muhammad Akbar. I'm interventional cardiologist at Western Kentucky Heart and Lung Associates, as well as faculty at the University of Kentucky Bowling Green campus. One of the best things that's happened over the last couple of decades in the field of cardiovascular imaging is the rapid improvement and advancement that's happened in the field of cardiovascular imaging. This revolution in cardiovascular imaging has greatly helped us improve our understanding of and management of different disease processes, whether we are interventional cardiologists, electrophysiologists, or heart failure physicians. This progress in cardiovascular imaging would not have been possible without the hard work of those trailblazers who dedicated their lives to the field. I have the good fortune of introducing one of those leaders to you. Dr. Vincent Sorrell is a cardiologist specializing in advanced cardiovascular imaging. He is currently the Anthony DeMaria Professor of Medicine, the Vice Chair of Cardiovascular Division, as well as the Program Director at University of Kentucky Gill Heart and Vascular Institute. Dr. Sorrell has published extensively during the course of his career. Having published more than 150 peer-reviewed publications, he's also the author of several books, including the first atlas on 3D echocardiography. He has an avid interest in the field of ischemia detection, 3D echo, and echo contrast. He's participated in several national and international trials, and his contribution to the field of cardiovascular imaging is greatly recognized. We've had Dr. Sorrell as a speaker in our past Cardiovascular Symposium, and it gives me great honor to welcome him again to update us on the latest in cardiovascular imaging. Thank you.
Okay, well, thanks very much for inviting me here today. I'm going to be going over advanced cardiovascular imaging. This is a talk that I termed sort of the silent partner, and you're probably wondering what that means. And well, as a cardiac imager, my thoughts are the following. When imaging is of high quality and the results are accurate, what you have is you have a cardiovascular procedure or a patient outcome that's usually successful, and the imaging person kind of remains in the background as a silent contributor to the care of the patient. The rest of the team, of course, receives the accolades from successful outcomes. But if imaging is incorrect, if the diagnosis is wrong, then the imaging is kind of heard around the world, because as imagers, we've resulted in what could be poor, misguided management and oftentimes a poor outcome. And so cardiac imaging as a silent partner is a good thing. And that's the way we like to do it, is stay in the background. So my disclosures are really none, no specific conflicts based on what I'm going to talk about. Off-label use of gadolinium contrast, thank goodness, is no longer an issue. This was now made available to us to use since last year, which is good because we've been using it for the last 20 years. And then I do have a number of sponsorships as well. So my outline today, what I've been asked to discuss is sort of a brief overview of advanced cardiac imaging, focusing on cardiac MRI and cardiac CT, and kind of address some of the new capabilities that challenge our conventional way of thinking about taking care of patients. And then I'll go over some really unique clinical applications of these tools, and maybe some research scenarios that allow us to really maximize the use of these advanced cardiac tools and demonstrate the role of this, quote, silent quality of cardiac imaging. Throughout the talk, I'll be giving you a number of case examples that help to drive this message forward. So New England Journal of Medicine, you may have heard of it, it's a pretty good journal, said basically looking back on the millennium of medicine, that medical imaging is one of the great medical developments of the past 1,000 years. So as a cardiac imager, I always like to show this slide and just sort of put it in perspective for everybody. I truly do believe, and I think many of us do, whether we admit it or not, that cardiac imaging has changed the way we deliver care to the patient with heart disease, and it's central to the clinical care and research investigations that we perform. So let me tell you about this 58-year-old man who came to see us. He had bypass surgery, he was having chest pain, he had heart failure symptoms, a really, really poor ejection fraction. And here's his cardiac MRI, and you're able to see on the two-chamber view just really grossly abnormal motion. This whole anterior wall is thin, dead. the apex is dead. The inferior wall appears to contract okay. The anterior wall is dead. Left atrium is big. And then the cardiac MRI is over here. You can see the ejection fraction is 18%. And the late gadolinium contrast was less than 10%. So with that information, you have some options here. One, initiate steps towards an LVAD and a transplant, which is what the referring institution suggested that they should come see us for. Two, offer bypass surgery, even though the ejection fraction is as bad as it is and he's in heart failure. Three, just, I understand he's a young person, but maybe all he needs is, compassionate care and palliative care, medical therapy, and tell him to live his life, go fish. Or, I have no idea what I'm looking at, and I appreciate you giving this talk. So this is me getting into an MRI scanner. This is from when I was training in London. You can see the cardiac MRI, the bore is a little bit smaller here. It looks like I'll barely fit in there. I'm really not that massive in size. And it looks like it's a relatively small bore, and many of our patients wouldn't fit in there. And that's probably true. Our MRI scanners that we use today are much bigger, much larger, and much more comfortable for patients. These are the kind of images that we can get with cardiac MRI. Sometimes we refer to it as the general store principle, one-stop shopping, where you can get anatomy and physiology. You can see function. You can look for scarring and viability. You can do contrast perfusion like we do with PET scanning. You can do angiography, non-invasive angiography. You can even in some research institutions get the coronaries. We do this routinely in the proximal vessels. We don't see the distal very well. And there's even some institutions out there looking for coronary plaque. You can look at flow. Here's a patient who has an atrial septal defect. Here's a patient who has an outflow tract obstruction. So with cardiac MRI, you're able to see really most anything you can get with an echo, with a PET, with a nuclear. It provides us with, I think, the reference standard today for left and right ventricular size, volume, and function. And we do that based on this images here, where we get high quality three-dimensional imaging, multiple slices through there to what we call this short axis stack. And each of these then can very readily be measured, traced, and a volume and an ejection fraction be provided. We also get incredibly high quality black blood imaging or spin echo imaging. Here's a patient with a dilated aorta, probably a bicuspid valve, and has a coarctation over here. We get white blood imaging, which is in motion. This is called a gradient echo image. And you can see the aorta here with a narrowing again at that coarctation, and then maybe a little post-stenotic dilatation in the descending aorta. And now what I want to do is go over what is the driving influence of why cardiac MRI has become such an important tool. And that's really contrast enhancement, gadolinium contrast, not iodinated contrast like our patients that have renal problems with. This is a paramagnetic agent that we inject. Gadolinium is one of our elements on the elemental chart, and it's bound to albumin so that it's not going to be toxic. And when you inject it, basically you get a lot of contrast in there. You get a bright signal, and if you don't have much contrast, you get a dark signal. So the signal intensity goes up with contrast. And you can see here at this area, we inject contrast, and then we have this timeline. And what happens initially, if we focus on this red normal myocardial line, is you get this very high, bright signal, and then it washes out, and over 10 minutes, it's gone. So normal contrast into normal myocardium gives you a very high signal. And then over time, it disappears. So bright early is good, dark bad, dark later is good. However, if you have a defect, let's say you have ischemic myocardium, you've got a coronary stenosis, that very early increase in intensity is going to be reduced, and you have a deficit, a difference. That difference can be detected on first pass imaging, and that's what we do with stress testing. So within 30 seconds of injecting contrast during, say, vasodilator stress or even exercise stress, you can see there's reduction relative to the normal area. That's going to be a perfusion defect, just like nuclear. And then over time, that washes out. And now you can focus on this area here, where if your contrast has trouble getting in and then it sticks around for a really long time and you have this delayed phase, you get increased signal intensity. And that tells you that the myocardium itself is not normal. And it may be an infarction, it may be something else, but a myocardial infarction, you don't have packed tight myocardium that allows the contrast to wash out, but instead it provides an environment for the contrast to stick around. Contrast should never stick around in myocardium. That's always bad. So again, let me summarize. Normal, you want to have high, bright signals. Normal, you want to have no signals late. So here's just an example of what happens if you actually stain a heart with a myocardial infarction. This is an animal study that was done now over 2 decades ago. And it was really a sentinel study changing the impact of cardiac MRI. And you can see here, there's this scar, very, very well defined with the staining of where the abnormal dead tissue is. And then there's this intermediate sort of darker red, and then you have this pink, which is normal myocardium. And then here's the MRI showing the exact almost overlay of that scar. And it's striking that even these intermediate zones with this very high spatial resolution, because the heart is not moving, it's a necropsy study. But you can see even the details of the in-between zones of the scar and the normal can be picked up. This is incredible. So how does this play out in animal and in human studies? Well, here's an example, again, viability imaging, or what we call scar imaging, because we can detect areas of scarring. You can see here's a area that's black, which is normal, white, which is abnormal, black, which is normal, white, abnormal, and very well defined. It's the endocardial border, not the mid-myocardial, not the epicardial, but the endocardial. And this is the watershed territory of a myocardial infarction. And even over here, you have normal myocardium, except in this inferior wall here on the 2-chamber, the inferior wall, very small infarct. This is example of an RCA infarct. So this is basically LAD, circumflex, and RCA, what it looks like. What would this look like if you did a SPECT scan? Well, here's 3 examples of a nuclear SPECT, and you can see 1, 2, and 3 are all normal. I'll ask you, if you're a nuclear imager out in the audience there, to take a look at this. Do you see a scar? Do you see an area that you would call a perfusion defect on? And I've looked at this many times. I suspect, like me, you would read it as normal. If you look at the MRI, though, it says, wait a minute, there's a scar right here, and here's the correlating area. There's a scar here, again in the inferior area. Here's the correlating area. And then there's a scar in the anterolateral, and here's the correlating area. And there's no evidence here of these small, and that's the key here, small myocardial infarctions. If you actually look at these post scar, this is an animal study, so we were able to actually look at the tissue, and you can see that all 3 lined up again to those, even that small area anterolaterally lines up to the true representation of a myocardial infarction. So what does this tell me? This tells me that nuclear has low spatial resolution, MRI has higher spatial resolution. Therefore, nuclear will tell you correctly that this patient has normal scan in the sense that they should do okay. So their clinical outcome, their prognosis from this result is good. The MRI says, well, the nuclear is not correct. There actually is a small scar. And we prove that by looking at the pathology. But it also tells you that overall they should do okay, but they're not going to do as normal as somebody without a scar. So this is critical. This is what we say is the discrepancies between the different imaging tools. So where does MRI provide the greatest impact? I think it's probably in our patients with heart failure. With non-contrast images, we don't need to worry about renal patients and giving contrast, because we can get ejection fraction and volumes of the left and the right ventricles, as well as look at the pericardium without giving contrast. And then with contrast enhancement, as I just showed you, we can look for areas of scarring and fibrosis in the myocardium, which helps us making diagnosis of coronary disease or dilated cardiomyopathy. It provides us with greater insight into whether or not a patient would need an ICD, whether they have another unexpected diagnosis, say a hypertrophic cardiomyopathy. And now we have tools where we can look for myocarditis, amyloidosis, cardiac sarcoidosis, cardiac chemotherapy problems. We've known for a long time that if you have any gadolinium in your heart, and that's this lower arrow, your outcomes are worse. And we've known that if you have markedly reduced ventricular function, you can predict some recovery of function based on the extent of the scarring. So here's that first patient I showed you who had a really sick heart. You can see the 4-chamber view, very, very thin septum, gone, apex, lateral walls gone. The anterior wall in the 2-chamber view is very, very thin. So this is the heart that, we were asking the question, what would we do? So in this particular patient, when we gave the gadolinium enhancement, you can see there's a little thin scar over here on the lateral wall, but it's less than 50% of the myocardium. The apex has a little scar. The inferior wall has a little scar. The anterior wall has a little scar. So there are some areas where, this really horrible multi-vessel, 3-vessel disease patient has had previous events. But there's also a lot of muscle here that's trying to live. So this is what we call hibernating myocardium. Chronically low blood flow that has altered its contraction patterns to the point that it's it's living on its last breath, if you will. And so what it's done is it's sacrificed its contraction patterns to maintain cellular viability, cellular life. And all it is asking for you to do is to give it back blood flow. So instead of doing a transplant and losing this heart, we actually opted to do bypass, knowing that we might have to do a device as backup. And here's what this looked like after bypass. And I just want you to look at this for a second. To me, this is kind of eye-opening, especially if you look at this two-chamber view. Remember that thin anterior wall in the apex? And look how the wall is plumped up. So you've got normal thickness and an ejection fraction that's almost near normal. There's some loss of function way out at that apex. Here's the side-by-side showing you again, thin anterior wall, gone apex, post-bypass. This patient did great after bypass surgery. They flew without needing any kind of device and barely needing any jet fuel coming off of a pump. So again, really eye-opening study telling us that with MRI, we can quantify the degree of dysfunction, but importantly, we can anticipate whether there's enough myocardium to offer revascularization and possibly save somebody a transplant, which is what this patient was being driven for. Well, let me walk through some other MRI studies that are, I think, meaningful to us. We know that implantable cardioverter defibrillators save lives. Here's a patient with ventricular fibrillation, complex VTAC, maybe polymorphic VTAC, and then boom, they get zapped and the heart lives. So that's one way they save lives. Something you probably haven't seen before, this patient was actually shot, and you can see that the ICD saved a life from another reason. Here's the bullet actually as it gets impacted into the device. Sudden cardiac death provides us with a bit of a paradox. This is an area I used to study a lot when I was at University of Arizona. We would take all patients that were getting ICDs and we would scan them with MRI prior to that across the entire city of Tucson. And you can see that implantable cardioverter defibrillators, we know that they're effective for primary prevention when the ejection fraction is low. But we also know that most cardiac events occur in patients with an ejection fraction over 35%. Right? 1,000 times a day, 350,000 sudden cardiac death events a year. So we have this incredible opportunity to identify patients with an EF that's higher that would not get primary prevention, but try to say, hey, is there something else in there that would guide a benefit of an ICD? If we look at the overall profile in the US of sudden death, total incidence versus total events, we know that over here, 20 million Americans have coronary artery disease, 800,000 new MIs annually that we know of, and those with an ejection fraction less than 30% or an out-of-hospital cardiac survivor or in the convalescent phase of VT after an MI, those are the patients that are getting ICDs, and they account for about this many events overall. But if the patient has had any prior cardiac event, they actually have more events per year than the overall combined total that we're currently putting ICDs in. So wouldn't it be great if we had the ability to look for prior cardiac events? Well, what's the data on this? Sudden cardiac death prediction by cardiac MRI, looking at the percent of late gadolinium enhancement, we can quantify it as greater than 20% or less than 20%. And it so happens that that mark, and this is 20% of late gadolinium enhancement relative to the myocardial mass. And so you can see that if you have increased late gadolinium enhancement, you have an increased risk for sudden cardiac death. And it precipitously drops each year. So by 1 to 2 years, you've already had a significant change. Well, what do we do, right? What do we do here? What's our recommendations? Our recommendations say if your EF is low, you get an ICD for primary prevention. And this is the graph, the classic graph that shows us that ejection fraction can risk stratify patients. And here's the probability. You can see this tight line between what is at risk with an EF over 40 versus under 40. And these lines are pretty close together. They separate early, but they don't separate greatly. So if I draw this curve straight like I drew the other curve, here's the MRI curve, or this is the curve that I just showed you, but displayed similar to how I displayed the MRI late gadolinium curve. And here's overlying those two curves on top of each other. And so what you can see is the red line here is our ejection fraction's ability to predict events. And the other red line is our cardiac MRI's ability to predict sudden cardiac death events. And so I believe, and I'll leave you with this sort of thought out there, this exciting possibility that we might evolve and transition to a new tool to identify who should get ICDs. And my hope is that, we continue this line of research and we come up with better tools, because we know currently it's a very cost prohibitive plan. Every time an EF is under 35, they get an ICD. They live with that ICD for 20 years. It never fires. The cost is extraordinary, and the risks associated with having an ICD, but it never going off is unacceptable. What about heart failure with preserved ejection fraction? We've been talking about reduced ejection fractions, and everybody wants a magical pill to treat HFpEF. But I got to tell you, HFpEF is not a disease. HFpEF is a byproduct of a whole bunch of diseases. All it's saying is that you have heart failure and you have a calculated volume difference from diastole and systole that's normal. So there's no way that you have a category of HFpEF that would be enrolled in a clinical trial, such as spironolactone or digoxin or whatever you want to study, that's going to show reduction in events consistently, or reduction in or improvement in clinical symptoms consistently. Here's a study. I love this study. It's called the Diamond HFpEF study. It's a cardiac MRI study. And you can see 4 different patients that were entered into this trial because they had HFpEF. It was a prospective trial. They excluded known causes of heart failure. So this wasn't like they were trying to show the power of MRI. These were patients with HFpEF, but no known underlying cause. And if I leave you with any message, it's make sure you figure out what the cause of HFpEF is. Please. I think MRI will help considerably in that question. Out of 138 eligible subjects, they had a whole bunch of patients with a dilated cardiomyopathy, which is this mid-wall fibrosis. They had a whole bunch with ischemia. They had a number that had fibrosis at a what we call a benign pattern, a whole bunch of silent myocardial infarctions, hypertrophic cardiomyopathy, even some constriction and amyloidosis. And the examples I have up here, this top left is an example of cardiac amyloidosis. Top right is an example of hypertrophic cardiomyopathy with this thick interventricular septum, which is regional and asymmetric relative to the lateral wall. This patient has a bright white shell sitting around the heart there on the bottom left. That's constricted pericarditis. And this patient over here has normal, nice, bright, dark myocardium, which is normal. And then this little area at the apex, because they had an old infarct. So this patient has coronary disease. Well, there's no way that all 4 of these could be put into a single clinical trial for HFpEF and expect to have success of whatever drug treatment you're trying to do. So if you are interested in HFpEF and you want to do a clinical trial, please do an MRI first, categorize them, and then study a population that is consistent. So here's my value equation. I like to do this with all with all imaging tools, right? CMR, what does it equal? It's the benefit cost ratio, right? So if you look at the benefits, right, it outperforms echo, SPECT, PET. It's a mature technology. I've been doing this now for 20 years. It gives you, like echo, it's a comprehensive tool. You could argue it's like echo on steroids because of its ability to really provide you with detailed, comprehensive data. It's our reference standard already for many diagnostic and prognostic questions. And you get immediate results, just like you do with echo. You do the study immediately after you have what you're going to try to call some referral on, what you found. And then there's the cost. And the costs are unfortunate. You have to travel to an expert center. This is not something that's available everywhere. There's potential claustrophobia. There's the safety issues with whether we do it with pacemakers and ICDs, but not everybody does. There's the rare nephrogenic systemic fibrosis. So we don't like to do this if your GFR is under 30. And there's this potential concept of it being an expensive test. But I believe that expensive shouldn't be the cost of the test. It should be the cost to the healthcare. And sometimes paying more money up front, you save money downstream. So the low current use of CMR in the US today, because I do believe it's grossly underutilized, is a lack of knowledge among physicians. As we continue to harp upon our administrators and let them know how important this tool is in the management of our care of our patients, we'll have more people providing these skills. Inadequate technical capabilities of the majority of the medical scanners. Just because you have an MRI doesn't mean you can do cardiac MRI. There's a paucity of CMR expertise, few training centers. I'm proud that we've every year put out a couple of new advanced imaging fellows that go into practice and start their own programs. And then there's, again, this perceived cost relative reimbursement compared to interpretation and time commitment. Not everybody likes to spend the time that it takes to read a high quality cardiac MRI. And if you want to do it, you're going to take the time to do it. Then it becomes cost beneficial by decreasing downstream testing. All right. So as you can see here, this is a CAT scan. So I finished up cardiac MRI briefly. I'm going to run through cardiac CAT scans, and I can assure you no animals were harmed in the taking of that picture. Unlike stress test or stress echo, SPECT, this is anatomic imaging. So when we do a cardiac CT, we actually look at the coronaries. So the way to think about it is not compare it to stress testing, which is what everybody wants to do, but to compare it to cardiac catheterization, invasive coronary angiography. You need to have a multi-detector CT scan that's at least 64 and ideally 128 or better. You have to slow the heart rate down. Patients have to be able to hold their breath. You give a little bit of contrast. So there is the issue of contrast, and patients therefore need to be well hydrated, and renal issues and allergy issues need to be addressed. There's exposure to radiation, but it's minimal. We keep it down to really a few millisieverts, much less than nuclear, because nuclear on average is over 10 millisieverts per test. And if you want to do physiology, you have to send it out. So here's just an example of why we want to have a big multi-slice, multi-detector scan. A 64 slice allows you to get this much of the heart for each beat, which means you have to stack multiple 64 slice scans together to give you a complete cardiac tree, whereas a 256 slice would give you the entire cardiac tree, and therefore you don't have the artifact of slicing together and splicing together image data. Well, you may or may not have seen this. This is that medical journal called Time. Amazing detailed heart scans help doctors spot trouble without surgery. As if you need surgery to spot trouble, I don't know. And then I remember watching this way back 20 years ago when Oprah was on Oz show and showed this heart and said, look at these beautiful big coronary arteries. And he tried to imply that this was a normal coronary angiogram. And I got news for you. This is awful. This is coronary artery fissure of some sort. It's just massive, big dilated coronary. But either way, he's trying to drive a message home that we had this new technology called cardiac CT. But I remember at the time, I was like, oh, this is crazy. This is not a CT scan. This is a CT scam. And I base that on this. This is sort of my imaging timeline of how we compare the scientific data that supports the use of imaging with the growth and the knowledge that's gained from publications of the clinical value of that imaging test. And if we look at echo, we've got many years now, 60 years, showing that as the scientific evidence grew, the use of echo grew. If we look at MRI, the scientific evidence is way ahead of the growth. And I sort of explained to you why that's the case. And so we really need to change this timeline and start to catch up to the value that is brought to us by cardiac MRI. But here's what CT did. CT was way ahead of the scientific evidence. So we were doing cardiac CTs, and they were on the back of most medical journals. You saw posters, get your heart saver, watch your kids graduate college, this kind of stuff. I remember going to a heart ball where they were giving out raffles to get your cardiac CT scan, what was called a heart saver scan. This was, again, 15 years ago. And we did not have the evidence to say that was there. What we had was beautiful pictures, and people just assumed the evidence would catch up. Well, the good news is, guess what? The evidence has caught up. And now we're starting to really close this gap. And we're going to soon over here have great data. And I would argue this arrow is much closer together now. Here's our first image. This is a non-beating heart performed in 1972. You can see unreadable, basically, heart scans. And that's why many radiologists just simply don't look at the heart. They see this blurry thing in the middle of the chest and they just stop. These are the kind of images that you could expect today. This is a 3D whole heart image showing you the LAD circumflex, the diagonals and obtuse marginal branches. Here's the coronary veins coming around. Just really high quality images. And this is anatomic. It's not physiologic. So wouldn't it be cool if not only did we get anatomic data, but we got physiologic data? And I'm glad you asked. The question has been answered. We now have the ability to also take this anatomic map and to match it with a physiologic map. So this green is normal, yellow is not as normal, red is starting to reduce flow. So this LAD pattern over here, and then suddenly this red branch is grossly abnormal. This is reduced flow. So this is called FFRCT. Now, what is FFR? We'll talk about that in a second. Where does CT stand in our guidelines? Well, internationally, CTA has caught up to the guidelines. It's now a class 1 on par with stress testing, and it's a class 1A on par with invasive coronary angiography. If you have an equivocal stress test, you don't have to go straight to the cath lab. You could basically get a cardiac CTA. Whenever we do a scan, we also look for hardening of the arteries, right? Calcification. Calcification is an incredibly great marker of the presence or absence of atherosclerotic disease. if you look at this image here, this is a coronary angiogram. You can see the arrow is pointing to where the intravascular ultrasound, the intracoronary ultrasound is being imaged. So this vessel looks perfectly normal. And here's the angiogram showing us atherosclerotic disease within the vessel. Again, the angiogram is read as normal. So we have to look at this and say to ourselves, well, what's going on here, right? Normal angiogram, slice through it, take that short axis view, and you begin to see that this normal luminogram performed invasively is not looking at the eccentric borders, but it's looking at the smooth central borders. And that gives you the possibility that the lumen is okay. It's all normal, beautiful sized normal lumen. But the eccentric plaque, which is Gladkoff's remodeling plaque, tells us that there's extensive coronary artery disease. So when we get a calcium score, we're starting to tell you that there's this remodeling that's occurring, and some of this over time becomes calcified. And so it makes sense that a normal angiogram could be in many ways thought of as a false negative. Yes, they don't have obstructive disease, but don't let that fool you to saying that they have no coronary disease. They have no obstructive disease, but they may have coronary disease. And so our ability to use calcium score, just simply calcium, no dye, no contrast, and just categorizing our patients, and now we use 300 instead of 400 as an event predictor. And you can see that there's incredible ability to predict events in those under 45 and even those over 75. Think about that. Coronary calcium score of 0 in somebody over 75 years old, they have an average mean survival of 5.6 years. If we take our patients that have over 75, and you can see that based on the range of calcium that you find there versus a calcium score of 0 has a huge incident event increase for mortality. So calcium score is really powerful. I think it's a great way for us to help identify whether there's absence or presence of disease. And here's just a simple case example of a 52-year-old man who comes to you. Maybe his atherosclerotic risk is sort of in between. And so you order a calcium score, never had chest pain. The patient on the left has beautiful coronaries with no calcium. The patient on the right has extensive, severe coronary calcium involving all 3 coronary arteries here. So you can see left main, intermediate, or high diagonal, circumflex, and LED, they all have disease. So before the scan, you might have been questioning the role or the benefit of aspirin and statin, but I think after the scan, you would have a different understanding of what to do. What about our Framingham risk scores? And we know that they're notoriously imperfect, but if we look at not just the intermediate risk, where you take the intermediate Framingham risk score, you have a wonderful ability to further stratify the patients by using calcium presence or absence or the severity of the calcium. But if you take your low risk Framingham risk score and they have a lot of calcium, they're multifold increase for events. And if you take the high risk and they have significant calcium or not, you can have a 4-fold difference in what their event rates are. So calcium score cardiac events way outperforms your ability on any kind of scoring, and Framingham risk score is shown here. But that shouldn't surprise us because we've known for years. This is many years old data from Bill Little. And you can see here that the survival of patients with mild disease versus severe disease, this is angiographic data. This is back when we did cath, and that's all we had to look at coronaries. And if you take the group with 50% mild disease getting medical therapy versus those over 70% of all 3 vessels, look at their lines of survival from the cath study. They overlap. They overlap. So we shouldn't be surprised that the lesion severity alone is a poor predictor of survival, and we need more information about both the presence of eccentric plaques and the hemodynamic significant tools of the atherosclerotic plaques. And so that brings me to FFR. So fractional flow reserve is now considered the standard, I believe. It's a measure of the flow difference across a coronary stenosis. So you think about it, it's the pressure after divided by the pressure before. So if the pressure drops across a lesion by 20 to 25%, the FFR would be reported as 0.8 or 0.75. So this is what's considered now to be a significant drop, depending on which data you look at, either 0.8 or 0.75, invasively or non-invasively obtained, is a important finding that that's a physiologic significant lesion. hemodynamically significant lesion. So let me tell you about a patient, a 57-year-old male, came in with chest pain. We did a CTA, and you can see there's this intermediate lesion. This is one of our older scanners. There's a little hard plaque up here near the top of the right coronary artery. And then there's this mid-vessel narrowing. We thought it was intermediate. We continued to medically manage him. He continued to have pain. And just like you do with a stress test, if you have discrepant findings or they continue to have symptoms, you perform an invasive coronary angiogram. And so this patient went on for an invasive coronary angiogram. And you can see here's the angiogram and how it lines up. They found an intermediate lesion as well. So now we've got a non-invasive and an invasive coronary angiogram. They're both showing intermediate lesions. We need to have something else. So we could stop here and go order a stress test, or we can do a stress test right in the cath lab. And that's what we do nowadays routinely. And that's FFR. So this patient had an FFR and the pressure before and after were compared. And this one only had an 8% change. So it was considered non-significant. And we now will search for other causes of pain, believing that this lesion alone is probably not the source of his angina. So then we didn't have the non-invasive FFR capabilities back when we did this, but we do now. So we went back and took this lesion and we ran an FFR test on it. And you can see here was what the FFR, it was all green. And our calculated FFR was 0.93, which correlates really well with what we had invasively. So think about that. Had I had this tool on the right, this FFR tool on the right, at the time I did that, maybe we wouldn't need this in the middle. So the question is, do we have more capabilities today with CT and FFR CT to actually prevent the need for the invasive coronary angiogram? And the answer to that is yes. We now know that we could reduce the burden of non-obstructive disease showing up in the cath lab by using CTA FFR guided decision-making. You can see here that 73% of patients end up not needing to have anything done when they go to the cath lab. But that number can be greatly reduced by over 80% if you use CT FFR guided, meaning that we can defer the need for getting into the cath lab at all. We now are involved in a precise trial. If you have any questions on that, I'd be more than willing to talk about the patients that we're looking at and what we believe is a future precision way to manage patients with stable ischemic heart disease. All right, so that's MRI, that's CTA, and now for the last few minutes, what I'd like to do is kind of run through sort of a gamut of scenarios of where we're using advanced imaging and maybe address some of the other speakers, because I know they're going to be talking about stable ischemic heart disease and cardiovascular mortality, nutrition, the rising tide of congenital heart disease, atrial fibrillation I'll touch on, COVID-19, and a whole host of on-demand subjects. And my hope is that you really are enjoying what is a virtual, very unique 2020 virtual presentation of Kentucky's ACC. So atrial fibrillation, again, I tell the fellows all the time, this is about opportunity meets capability. So here we know that atrial fibrillation causes strokes. We're constantly trying to improve symptoms, but also reduce the risk of stroke. And we do that a couple of ways. One is we put things to close off the left atrial appendage, because we know that's the sucker that causes clots to form. And here's on CT, just showing how beautiful we can see detailed images of that left atrial appendage. So right here is the left atrial appendage. And in surgery, people could actually tie it off. So if you ligate the left atrial appendage, that must be perfect, right? Well, unfortunately, it's not. And we end up with oftentimes what we call incomplete left atrial appendage closure. So if you take a look here, you can see that they've tied off the left atrial appendage, but with echo, you can see a little bit of flow going around it. And here's just an example of that patient in sinus rhythm with flow coming into that lesion. So I guess you need to realize what CT would look like. And here's a complete left atrial appendage closure. You don't see an appendage at all after surgery, versus this patient over here, where the left atrial appendage, we color-coded it for your ease of seeing this. But you can see the left atrial appendage is still this complex structure. So yes, you tied it off, but no, you did not decrease the stroke risk, because clots can form in there and like a watermelon seed goes squirting out systemically. And it turns out that that's not uncommon. 35% of the time, a ligated left atrial appendage is left patent. So in your patients that you are seeing, they have atrial fibrillation, they come to you and they say, oh no, doctor, my surgeon tied it off. I don't need anticoagulation. I don't believe that's true. But if you want to know for sure, you can get a cardiac CT and see the success of the ligation. Well, what about the aorta? Clearly, we need a better understanding of aortic pathophysiology beyond just measuring diameters. We spend so much time, what is the diameter? Is it beyond or above a certain threshold? But we really don't talk about the physiology, the flow, the ventricular aortic relationship. So we need a lot more data. And I think with advanced imaging, we can get a lot more data on the aorta. This is a CT scan. You're able to see, again, a bicuspid valve. Beautiful example of a congenital bicuspid valve. Here's the coronary artery over here with the arrow. And we published this because this was a patient that was unanticipated to have this dilated ascending aorta, had to go for surgery. And we've known for a long time that the rate of aortic dilatation is faster in a bicuspid valve than a tricuspid valve. But we've never really fully understood it. I could talk all day at what my hypothesis is, but let me just throw out there this idea that maybe flow has something to do with it. With MRI, we could look at flow in a very complex pattern. So this is what we call 4D or 7D flow. And what we've done here is we've looked at each aspect of the flow within the aortic tree. And this is with a cardiac MRI, and we can label this out. And this is a normal trileafed valve with a normal aorta. And you can see a nice normal striated pattern, even going up into the neck and the great vessels. In this patient in the middle who has a bicuspid valve, you can see the direction of the jet goes shooting over to this anterolateral wall of the aorta. And that's a common place where aortic dilatation occurs. Or this type of bicuspid valve where you get this spiraling circular flow, and these patients actually have an aortic root dilatation. So, we've known from Jane Sorrell and others, you need flow to grow. So you can imagine if you're born with a bicuspid valve and over time the flow has been in the aorta like this, as your aorta is growing, it may impact what the aorta grows like. This is that same patient here. This was the type of bicuspid valve they had. Here's just an example of a normal patient. This is, again, just showing normal aortic flow. And this is a patient now with a bicuspid valve, very turbulent, chaotic flow. Look at that aorta. Very complex pattern of flow within the aorta. Again, it shouldn't surprise us that the aorta would be non-normal. What is the value of MRI in clinical trials? Why is it that pharmaceutical companies and industry want cardiac MRI studies? And here's the answer to that. If you wanted to monitor the impact to a hypertensive agent, you would want to, over time, see its impact to the development of wall thickening or myocardial mass. So if you designed a trial to say, I want to see 10-gram change in LV mass at a 90% power with an error rate of 0.05, two-dimensional echo would need over 500 patients enrolled in a clinical trial for a year to show that degree of difference that was significant. So how many studies and for how long would you need cardiac MRI for your trial? And the answer may strike you. 14 patients for 6 months would be able to detect the difference. And this sends the message of the incredible spatial resolution power and the retest lack of observer variability and the reproducibility of testing. And that's why we can get away with many less exams. Well, last couple of slides here. This is we all know that TAVR and aortic stenosis is a thing that's here. We have this incredible ability to now percutaneously fix the aortic valve. But the success of a TAVR program is truly critically linked to advanced cardiac imaging programs, whether you're talking about patient selection, the optimal performance of picking the right device to put in, and then the success and long-term and short-term impact of what the valve looked like after you put it in. You have to have multimodality imaging. Here's just an example, a 3D echo showing this really complex trileafed valve that's not opening. And here's a CT showing heavy calcification of that same valve. But let's look at this study, and I want you to focus on this. Is a cardiac MRI study of patients that underwent a cardiac MRI before they had their TAVR, okay? Or before they had their surgical aortic valve replaced. And so they all had symptomatic severe AS. So what do we know? We know that these are patients that before they have symptoms and after you fix the valve, their symptoms should go away. So they did a biopsy, and you can see they categorized their patients into no fibrosis, mild fibrosis, or severe fibrosis. And then they went on and had their surgery. Now take a look at this. New York Heart Association functional class on the side. And you can see those with no fibrosis had fewer symptoms, and they all got better after surgery. Those with mild fibrosis had fewer symptoms, but almost all of them got better after surgery. But those with severe fibrosis had more symptoms, And look what happened after surgery. They didn't get better. So these are all patients with severe aortic stenosis, symptomatic, undergoing valve replacement. And this is telling you that the reason they get better or not get better is not the gradient, not the severity of the stenosis. It's the myocardium underneath. Well, with that in mind, I think we need to rethink about aortic stenosis imaging. Yeah, we can look at the valve and we can tell you is it mild, moderate, severe. And we can talk about the extent of calcification on the valve as a predictor of mild, moderate, severe. But I do think that we also have to now match what we can do with myocardial fibrosis. And MRI provides us an opportunity to look for this. And maybe what we're going to do in the future is start to look with CT and echo early on, but as the valve progresses, we start doing myocardial fibrosis assessment and then either offer anti-fibrosis treatment or maybe early surgical valve replacement as a means to actually improve symptoms before they get to the point where they're irreversible. So I've gone through a whole lot of things in a short period of time, and I'll leave you with a few final thoughts. I do believe that you need to have an advanced cardiac imaging expert. And what I mean by that is somebody who understands where their skills are, what their limitations are, and what the advantages and disadvantages of the various imaging tools are that are at your disposal or that you can send patients off for. With advanced cardiovascular imaging, we could truly impact healthcare delivery. We do this by detection of early disease, where we have an opportunity for more avenues of prevention. We have the ability to identify different cardiovascular phenotypes and then offer secondary prevention. Through the use of advanced imaging, you can see we can improve our ability for novel drug developments. And then again, I think my hope in my time on this planet is really to do a better job of matching imaging to outcomes. Imaging is a surrogate to patient outcomes, and we need to do a better job of reporting what those surrogates are. So these are all the opportunities that I believe exist. And if we look at multimodality imaging, it does add complexity. These are the challenges. So we have to look at the value, appropriate use, and comparative effectiveness. If it's minimally effective over another tool, and you're very skilled at that other tool, then you should offer that other tool. But we need trials, comparative effectiveness clinical trials, to show where its value lies. We know that the impact on efficiency and patient care and outcomes need to be studied. It's not good enough just to say that I could do X faster, therefore I should do X. That's not always the case. And of course, whatever we do, we need to avoid downstream testing, layering of tests, while simultaneously being aware of the radiation exposure to our patients. I do believe strongly that we all need to step up and do a better job of our patients coming into an emergency room and getting a CT scan with minimal thought. We all, I think, provide an impact into reminding our patients to say no and talking to our healthcare providers to think twice before they get a test that may or may not actually change management of the patient. So in the end, the danger of a non-invasive test is not its performance, but it's actually in its interpretation. I tell the fellows all the time that an echocardiogram is thought to be a very benign, simple test. But if you're making the wrong call and that's leading to additional downstream testing, then you should take ownership of that incorrect test. It was no longer a benign test. So stay focused out there. Remember that advanced cardiac imaging can be fun. Make sure you know what your tools are, your skills are, and what you're capable of, but also understand when you need to go elsewhere to get additional tools. And with that, I'll leave you and thank you very much for your considerate time.